Good morning, everyone. My name is Amy Carrera, Shield Healthcare's Corporate Registered Dietitian. Welcome to today's webinar, Preventing Urinary Tract Infections in Seniors, presented by Capital Nursing Education. UTIs in seniors are often mistaken for the early stages of dementia or Alzheimer's. This webinar will explain how to identify those at increased risk and implement strategies to recognize subtle or atypical symptoms. So some quick housekeeping items. The webinar will be recorded in case you missed any part of it. You can go to shieldhealthcare.com/webinar after this live recording to see it. There you'll also find a copy of the presentation slides. The webinar will be in listen-only mode. If you have a question, please type it into the question box in the control panel on your screen. There will be a question and answer session at the end. We're pleased to welcome Barbara E. West, RN, MSN, CWOCN of Capital Nursing Education. Barbara received her Master's of Nursing at Yale University in 1993 and her wound ostomy continence certification from Emory University in 2011. She has 12 years experience in hospice, and her experience in home health includes working with patients of all ages for both UC Davis Medical Center and Sutter. She has held several positions with Kaiser Permanente, most recently working in Sacramento at the General Surgery Outpatient Clinic and Vacaville Inpatient, performing full-scope wound and ostomy care. At this time, I'll turn the presentation over to Barbara.
Thank you, Amy. Good morning, everybody. I'm glad you could join us for preventing and managing urinary tract infections in seniors. Urinary tract infections are the most common infection in the U.S., and they're the most common infection among seniors. They're also the most common cause of bacterial infection in the blood, which is also called bacteriemia or sepsis. Today we're going to learn how to identify those at increased risk, recognize subtle or atypical symptoms as well as regular symptoms, how to manage UTIs, and we're going to introduce strategies for combating recurrence. Watch the big picture. Why are we concerned about urinary tract infections? For one, they hurt. They cause discomfort for most people. They can cause incontinence, and they can cause mental and functional status changes. There are also more immediate safety issues. Like I just said, the infection in the urinary tract can get to the blood and could be life-threatening if left untreated. Also, the treatments for UTIs can be dangerous. And throughout this presentation, I'm going to be using the term UTI for urinary tract infections. The treatments for UTIs, which is typically antibiotics, can also be dangerous. In addition, UTIs correlate with increased falls. When someone has a bladder infection, they're often rushing to get to the bathroom in time, and this can cause them to fall. They're having to go more often. And if they're incontinent, a wet floor can be slippery and be a trip hazard. We're also going to be talking about differences between men and women. In general, women are at higher risk for UTIs throughout their lifespan. One reason for this is that men have a longer urethra. This is the tube that goes from the bladder to exit the body. In the case of men, it's at the tip of the penis. We call it also the urinary meatus. And in women, the urinary meatus is located between their labia, and it's much shorter. So bacteria have an easier time climbing up the urethra to get to the bladder in women than they do in men. On the other hand, men are at higher risk for retention. Part of that's due to the longer urethra, but also the prostate, which we'll talk more about. So that can put them at risk as well. In women, another factor is that the urinary meatus is very close to the anus. So women are more at risk for cross-contamination from stool. Overall, 50 to 60% of women experience a UTI in their lifetime, and about 12% of men. Women over 85 have a 30% chance of having a UTI per year. All right, here's a diagram we're going to be referring to throughout this presentation. This shows the part of the urinary tract that's contained within the abdomen. So this is the part that's the same with men and women. What this diagram doesn't show is the very bottom part. You'll see the arrow at the bottom pointing to the urethra just shows the start of the urethra. So in the case of men, it's a long tube that travels the length of the penis, and in the case of women, it's a shorter tube that just exits at the meatus between the labia. So you'll have to just imagine that in this picture. But let's start at the kidneys. The urinary system is designed to work with gravity. Water flows downhill, urine flows downhill, and this is important when we talk about UTI risk, because we want gravity to be working in our favor. The kidneys are the main filter for our blood, and the kidneys are so important and so fragile in that way too, because a huge percentage of our blood flows through our kidneys every minute to be cleaned. And the kidneys draw out surplus water and waste products, and that's how they make urine. The kidneys then send the urine down the ureters. And I want to clarify here, a lot of people get confused between the term ureter and urethra. They look almost the same and they kind of sound the same. These are two different tubes within the urinary tract system. So the ureters go from the kidney down to the bladder. The urethra starts at the bottom of the bladder and leads to the outside. So I just want folks to be clear about that difference. And then we have the bladder, which is like a balloon. It expands to fill with urine, and then it contracts to expel urine. There's a sphincter at the bottom of the bladder, a little ring of muscle that helps to control when the urine flow starts and stops. And then we have the urethra that leads to the outside. As we get older, mechanical changes in the bladder and urethra may contribute to UTIs. One of the most common things, especially for men, is what we call increased post-void residual, meaning that after we go to the bathroom, there's still quite a bit of urine left in the bladder. Even in the best of situations, we can never get every last drop out of our bladder, but as we get older, we're more likely to be retaining a significant amount, and that can be a medium for growing bacteria. Also, as we get older, there are changes in the lining of the bladder, also called the urothelium, and this makes it easier for bacteria to stick to the sidewalls of the bladder instead of getting washed down. As men get older, they often have an enlarged prostate, which wraps right around that sphincter there at the bottom of the bladder, at the top of the urethra. And if the prostate is impinging the outflow, that's again going to lead to backed up urine in the bladder. Another factor as we get older for women is decreased estrogen. We're going to talk about that more later, but it turns out that estrogen affects the balance of healthy bacteria in the vaginal area, and this can put us at risk for bladder infections. Urine is normally sterile. In a young, healthy person, urine is typically sterile. So the conventional logic in healthcare is that if there's bacteria in the urine, there's an infection. We're actually going to be poking some holes in that commonly held belief. But for the purposes of right now, let's think about how the body keeps the urine sterile. And one of the main mechanisms is that flow of water. If you can imagine that a bacteria is like a little salmon trying to swim upstream. You know how when salmon are going up to spawn, most of them don't make it because the water flow is so hard for them to fight against. They're having to jump up waterfalls, and most of the salmon die before they make it to the top, to the spawning grounds. That's the same for bacteria in our urinary tract. They don't normally live in there, so they're normally getting there from the outside, meaning they have to swim up the urethra, swim up the bladder, and then eventually swim up the ureters in order to get to the kidneys, which we don't want. And so we're going to talk about how things like drinking more water makes it harder for the bacteria to get up there. You can just imagine a salmon trying to swim upstream. If we have a heavier flow in our river, they're less likely to get up there to the top, to our most vulnerable places. Okay, we were just looking at part of all of the upper urinary tract and most of the lower urinary tract in that diagram. Lower urinary tract infections are the most common, so those involve the bladder and the urethra, the outer lower part. And when we say UTI, we usually mean a lower urinary tract infection. The typical symptoms they produce in younger people are burning with urination, urgency, meaning that you feel like you've got to get to the bathroom right now or you're not going to be able to hold it, frequency, meaning you're having to go multiple times an hour, and you feel like your bladder's really full, but when you go, maybe only a few drops come out. It's a false feeling of needing to empty the bladder. And when you have that, you'll have decreased volume per void, cloudy or malodorous urine, and mental status changes. I know when I was young, I was very prone to UTIs, and I would sometimes get this feeling like a cloud was just coming over me, and I couldn't think straight. Upper urinary tract infections are much less common, but these are the ones that can be life-threatening. Pyelonephritis is the technical term for a kidney infection. If you have a kidney infection, you're likely to see a lot of blood in the urine. You might see clots. And then there's a fancy term, costovertebral angle tenderness, or sometimes abbreviated CVAT. Flank pain is what it's often referred to, but I find that confusing. I think of my flank as more along my side of my body. What this is, if you reach around to your back right now, just like make a fist and reach around towards your spine. If you reach up real high, if your arms are that flexible, you can feel your ribs. It's hard there. And then if you start sliding your hands down, once you get past your ribs, it's kind of soft. There's kind of a cushy place on either side of your spine. That's where your kidneys are located, right there below the lower margin of the rib. And so when someone has a urinary tract infection, if they're starting to feel tender right back there, that's a warning sign that their kidneys may be starting to get infected, or at least are getting irritated. And in nursing school, we learn to test for that. Sometimes people don't notice that it's tender, but if we thump there gently with the side of our fist, people will go, ouch, and then that's a sign. And one time when I had a bladder infection, I noticed just on one side it was hurting there, so I knew I needed to get antibiotics right away. Fever, nausea, vomiting can all be signs. When you have a kidney infection, you generally feel very, very sick. For folks that have urostomies, the upper urinary tract is the only part of the urinary tract that they have. So when they have a UTI, it's by definition an upper UTI, and it needs to be taken very seriously. Upper urinary tract infections can result in sepsis, bacteria in the blood, shock, or even death. Okay, this slide's very important. We're making this distinction between single episode versus recurrent UTIs. A single episode, meaning you just have one-time bladder infection, is just not that big a deal. We wouldn't even be doing this presentation if that was the main issue for people. You know, some people just get a urinary tract infection one time, they go to their doctor, get an antibiotic, it's the end of the story. We wouldn't need to talk about it for an hour. The reason why we're here today is because many people suffer from recurrent UTIs, meaning they're coming back more than 3 times in a year or more than twice in 6 months. And I want to just take a minute here to talk about the different ways that we diagnose a UTI from a laboratory point of view. The most simple is a urine dipstick. Some people even have them in their home. A medical assistant could dip a little stick into a cup of urine, a sample that you've given in the doctor's office. And that right away can tell us about the concentration and pH of the urine, and it has some chemical indicators to show if an infection is possible or likely. The next step up would be sending that urine sample to the lab to look at under a microscope, and that's called urinalysis, or UA. And they can actually see white blood cells in there, which would be a sign that your body's fighting bacteria. The next step up would be a culture, where a sample of the urine is grown in a petri dish to see, or is put in a petri dish and incubated to see if bacteria grows there. Like I said before, urine is normally sterile, so if bacteria are growing there, either we have a contaminated sample or it could be an infection. And then the next step after that is a sensitivity test. So we're growing bacteria from the urine in a petri dish, and then we test with different antibiotics to see, is this bacteria susceptible or resistant to various antibiotics? And you know, years ago, there was a big emphasis on doing all this testing, cultures and sensitivities, before starting antibiotics. But now that the thinking is changing, and we may sometimes be over-testing, and this Dr. Tricia Elliott had an interesting article where she said, We want to treat the person, not just treat the urine. So some of this presentation later on, we're going to talk about not overly emphasizing those tests. But right now, let's talk about general prevention strategies for everyone. Avoiding cross-contamination with stool, drinking plenty of water, don't ignore a full bladder. The National Association for Continence, or NAFC, recommends voiding every 2 or 3 hours. Unfortunately, for those of us who've struggled with recurring UTIs, the above strategies sometimes don't work, and it can be really frustrating. Avoiding cross-contamination. Number one, and especially for women, wiping front to back so that you're not bringing bacteria from the back, from the rectal area, towards the urethra. Thorough cleansing after bowel movements, and if someone has bad diarrhea or is incontinent, you might want to think about using a spray bottle, a sponge bath, or a shower to make sure the area is really clean. Changing incontinence products frequently can help. So think about it, if you have a wet pad or a wet brief, it can be a medium for bacteria to travel from the rectal area towards the urinary meatus. Avoiding very tight or thong underwear. We don't think of this being too much of an issue in seniors, but we want to be accommodate. We know there's a range of lifestyles out there, so for you seniors that are wearing tight or thong underwear, be careful that it's not getting moist and being a medium for bacteria to move forward. With catheterization, we're going to talk about this more later, but we've got to have the same kinds of precautions that we use when people don't have a catheter. I think a lot of folks feel like when there's a tube in the body, they're afraid to touch it. We're afraid we're going to pull on it or hurt the person. But a catheter needs to be cleaned the same way our body is cleaned. We don't want to pull on it. We want to make sure our practitioners are using good insertion techniques. And we're going to talk later about support devices to avoid it getting tugged on. But we want to just go ahead and wash the catheter the same way we wash the rest of our body with soap and water or cleansing wipes. We want to start at the meatus, right at the body, and then move outward so that we're moving bacteria away from the body. And sometimes we use an alcohol wipe to do this. It's not that we're sterilizing the catheter, but the alcohol wipe is just a nice, small, moist product that provides convenient, just the right amount of traction to slide down the tubing. The alcohol wipe can help us remove crusts or mucus, or a washcloth can as well. Anytime you have crusts around the catheter, that can harbor bacteria. It's important to drink plenty of water, but how much is plenty? National Association for Continence says, whatever you're drinking, increase it by 1 or 2 glasses a day. Again, they want you to be voiding every 2 or 3 hours. So if you haven't gone to the bathroom in 4 hours, then you need to think, hey, I'm probably not drinking enough. A great way to tell your hydration status is the color of your urine and the odor as well. There are certain medications or medical conditions that can affect the color, but by and large, if you're drinking plenty of water, the urine will be very light yellow, almost clear, and it won't have too much of a smell. So if you're noticing the urine getting dark or having a stronger smell, it probably means you need to drink more. Often, dehydration can be mistaken for a UTI. What if you don't like water? What about other liquids? The panel is not favorable towards most other liquids. Most of them have sugar or artificial sweeteners, and those are not good for the bladder. Sugar is the favorite food of bacteria, so anytime we're drinking something sugary, we're increasing our risk for a UTI. We also want to avoid bladder irritants like caffeine, alcohol, and artificial sweeteners. How can I encourage more water? Well, there's 2 sides of it. One is encouraging yourself, which I think is a little bit easier than trying to encourage somebody else. Herbal teas can be a great way to do this. My mom hates the taste of tap water, so she's constantly drinking herbal teas that don't have caffeine, hot or iced. And sometimes she just puts lemon juice in the water, and that makes it more interesting and makes it more fun for her to drink. Diluting juice is another option. We still have the sugar in there, but if we're cutting it in half, or better yet, 2/3 weaker than it was, that's a lot less sugar and a lot more water. If folks have dexterity issues, a sippy cup can be helpful. So can using a straw or a sport bottle. I know some folks who maybe they're sitting in their recliner chair most of the day. It's hard to get up and get a drink, so they get a giant bottle, maybe with a sport top, park it right there on their table right next to their recliner chair, and their assignment is, I got to finish this bottle by lunchtime, and then maybe a second one by dinner time. And so that way they can kind of monitor their progress. But you can lead a horse to water, you can't make it drink. And I've seen well-intentioned family members really hurt their relationship with their loved one by constantly nagging them to drink. So we'll talk about at the end situations where, you know, sometimes it's just not worth it to be constantly on someone's case to get them to drink. Yes, we're trying to prevent a UTI, but there may be other factors that are more important in your enjoyment of the day. So it's not, and also there are some people who just, it's very hard for them to drink, even to encourage themselves to drink. I think it's just people's constitutions vary. Cranberry products. There's debate about this. There's not clear scientific evidence, but a lot of folks still think that they make it harder for bacteria to stick to the lining of the bladder or urethra. Unfortunately, when you buy cranberry juice at most stores, it's usually cranberry juice cocktail. There's very little cranberry in there. It's mostly high fructose corn syrup or sugar. I know that Knudsen brand does make a just cranberry juice, and I think there's a couple other brands that do now. If you've ever drunk it, it's very different than cranberry juice cocktail. Some people say it's like drinking antifreeze or battery acid. So it can be hard to swallow. It can hurt your stomach. It's very acidic. And there's been times when I've used it to fight off an early stage bladder infection. I drank so much of it that I actually had burning with the urine and frequency and urgency because the cranberry juice was irritating my bladder. So you got to watch it. But I do feel that I've been able to head off urinary tract infections by drinking it in the very early, when I had the very early signs. For folks who can't tolerate it, they do make pills and capsules. I just want to say, when my son was like 5, 6, or 7, he'd been potty trained for a long time, but there were several times where he was just incontinent. He wasn't making it to the bathroom in time, had to change his clothes. And it would happen several times in one week, and I thought maybe he's got a little infection, and I'd have him drink just like a little shot glass or two of that just cranberry juice, which was very difficult to convince a 5-year-old to do, but it would clear it up. So that's my not-so-scientific study. And I noticed recently on the Mayo Clinic website, they still say it's worth a try, warning that it could cause stomach upset and not to drink cranberry juice with blood thinners like Coumadin or warfarin. I think part of the reason that the scientific studies aren't panning out is that they're mostly studying the pills and capsules, and after you drink that plain cranberry juice, you'll see why it seems more potent. But again, it's not worth it if it causes you suffering. Risk factors for UTIs. Anybody who needs a catheter is at risk for a UTI. An indwelling or Foley catheter increases risk significantly. Intermittent or straight catheterization doesn't increase your risk as much, and we'll talk about that more later. If you've had a previous UTI, if you have retention, if you're not emptying fully after each time you go to the bathroom, increased age increases our risk, as does being female. Diabetes increases our risk, for one, because what's bacteria's favorite food? Sugar. So when we have a high blood sugar as a diabetic, it's hometown buffet for bacteria anywhere in our body, but also our urinary tract. The other problem with diabetes is that the long-term high blood sugars affect our nerves, so our bladder is less sensitive. We're less likely to have the sensations that tell us we're in the early phases. And also the nerve damage that comes with diabetes can interfere with the muscles that promote full emptying of the bladder. Anyone who's immune suppressed, on chemotherapy, low estrogen, we're going to talk about this later. Neurological conditions like MS, paralysis, neurogenic bladder, and certain medications can put us at risk as well, especially if they interfere with emptying the bladder. I see this a lot in my surgery clinic. Folks have had general anesthesia, and then they go home, especially more common with dyes, and they just can't pass urine that next morning. And so they come in, and I'll put a catheter in just to make sure they're safe. Because if you think back to that diagram we were looking at of the urinary tract, if the bladder can't empty, it fills up bigger and bigger like a balloon stretching, but eventually it reaches capacity, gets to really high pressure, and then urine starts backing up the ureters all the way to the kidneys. That can put pressure on the kidneys, and that could lead to temporary or even permanent kidney damage. So when someone can't empty their bladder, it's an emergency. We need to get that bladder drained so that we don't put pressure upstream on the kidneys. One of the main risk factors for younger people is sexual activity, having a new sexual partner or multiple sexual partners. We don't think of this as much of a risk factor with seniors, but a lot of seniors are sexually active as well. Spermicides are another possible irritant. Most seniors don't have to deal with spermicides, thank goodness, but there could be some older men with younger women that might still have to deal with that. But that's one place that seniors are more off the hook. Passing urine right after sex can help reduce the risk in that way. Here's a picture of an indwelling catheter. We'll talk a little bit more about the possible benefits. Sometimes it is the only option, but the risks are it increases our chance for infection, and there can be odor associated with long-term catheter use. Alternatives to indwelling catheters, for men, they have an option of a condom catheter, a sheath that's rolled onto the penis that attaches to a collection device. And this can be a great option, and the risk for UTI is minimal or negligible compared to an indwelling catheter. There can be a risk for abrasions to the skin of the penis, but for men who can wear a condom cath, it's a great option. Incontinence products can be a way to manage if you're wearing the catheter for incontinence. Maybe just getting the right kinds of briefs or pads could allow you to not use the catheter. Sometimes getting more caregiver help, because sometimes it's hard for a person by themselves or with just one other caregiver to manage high volume incontinence. But if we have more help, we could do that and we wouldn't have to go to a catheter. A prompted voiding schedule where you're reminding someone to go to the bathroom every couple of hours could help them succeed at being continent, and then they wouldn't need a catheter for that reason. Environmental modifications, just anything that makes it easier to get to the bathroom in time, makes it easier for you to call for help. And don't forget urinals. We're going to look at those in the next slide. I also want to mention that in the US now you can buy toilet seats with washlet or like a bidet attachment, which has a water stream to clean the pelvic area. And this can be a great way to prevent infection and maintain hygiene, especially when folks have dexterity issues. Okay. Here's pictures of different urinals. This one on the left, the clear one, is the one for men that we typically see in the hospital. But I just want to mention that there are urinals made for women as well. They're not as easy to use, but depending on your dexterity and your anatomy, some women are successful in using urinals, especially women who are bedbound. And I think there are even some women who are wheelchair users who are able to use a urinal. So it takes some juggling, but I just want people to know that option's out there. Okay, situational risks versus benefits of indwelling catheters. Retention. If you can't empty your bladder, you need an indwelling catheter. We've got to empty that urine. It can be critical for the health of your kidneys. Sometimes I'm recommending an indwelling catheter for someone who has a pelvic area wound. I recently was seeing a lady who'd had a case of necrotizing fasciitis, which is a flesh-eating bacteria. It's very dangerous. She had emergency surgery. They had to remove all the flesh that was infected, which left her with very large wounds of the labia and buttocks. And so she was given a catheter, and she was actually also given ostomy surgery so that she had no stool in the area. Because the wounds were so extensive, we wanted to be sure there wasn't complication from moisture or bacteria. And she was healing great, and once the wounds healed, they were going to reverse the ostomy and she wouldn't need the catheter anymore. Incontinence, we'd rather find other solutions than an indwelling catheter, but sometimes it is the best solution. I just want you to know, in hospitals now, they're taking the risk of infection so seriously from indwelling catheters that in most hospitals, anyone who has a catheter, there's a daily round where the nurses and doctors are asking each other, do we still need this catheter today? And they have to justify why we're still keeping it one more day. Sometimes it's just too hard to get up to go to the bathroom. Some people have severe pain, and getting up to the bathroom is just too painful. It's not worth it. They'd rather carry the risk of infection with a catheter. Fatigue can work the same way. Sometimes with caregiver limitations, we have maybe a frail or elderly caregiver, or a husband or wife caring for their loved one, and they can't manage changing the briefs, doing cleanup, dealing with a possible accident in the bed, or the bedclothes needing to be changed often. So a catheter is how they're going to be able to manage at home, and it's worth the risk. In hospice, often we would see that where we just decided that for the convenience of the patient, for their comfort, we were going to have a catheter so they wouldn't have to deal with it and their loved ones wouldn't either. And in hospice, we're less concerned about the risk of infection because maybe it's somebody who only has weeks to live anyway. So the infection, the risk of getting an infection just isn't as significant. It's not a long-term problem. And other ways we can reduce risk if we're going to have a catheter is keeping that collection bag lower than the bladder. Again, we want gravity to be working in our favor, working against those little bacteria salmon that are trying to swim upstream. So keeping that bag low makes it harder for them to swim up. The same is true for a leg bag. Sometimes people are wearing a leg bag when they're up and walking during the day, but then when they're getting in their recliner chair, the leg bag's higher than their bladder, and that's not good. Also in a wheelchair, we want to find a way to position the collection bag as low as possible. Meticulous care of the spout or outlet of the bag when you're emptying it can help prevent contamination. Ideally, we want to maintain a closed system so that when the catheter is inserted, the tubing and bag all stay connected as they originally were. But if we're changing from a night bag to a leg bag, we're going to be breaking that closed system a couple times a day, and so we want to make sure to clean that well, let them rinse them well and drain, and have the cleanest technique we can to maintain that equipment. We want free flow of urine, no kinks or loops in the tubing. Again, just thinking of the salmon, we don't want any little places where they can rest and catch their breath to swim upstream more. We want to have a relentless downward flow. We want to empty the bag when it's a third to a half full, and we want to use catheter stabilization devices. We're going to be looking at these in the next slide here. Good perineal care is important, and the insertion technique. My teacher at Emory, Dorothy Doty, who wrote the book on continence, she found that even though nurses and doctors who are inserting a catheter, they do a cleansing with betadine or some other antiseptic, it actually helps if you take a shower first or just cleanse the genital area with soap and water before that insertion process gets started. Biofilms can grow on catheters, and so some of the newer catheters have these ultra smooth surfaces that bacteria can't stick to. Having a smaller balloon can help, because if you think about it, if you have a large balloon holding that catheter in place, there's going to be some retained urine there. The bladder can't shrink down as much. So a smaller balloon or a thinner catheter can help. Here's some of the stabilization devices, and again, nothing is without risk. We could have an adhesive injury from the adhesive kind. We could have a pressure injury or a constriction with a Velcro leg strap. But I really encourage folks to use these unless it's someone who's just in bed and not moving around at all, because anytime we're pulling on that catheter tubing, we pull out and then it tends to kind of bounce back in. We're introducing bacteria, and Dorothy Doty really emphasized the importance of minimizing traction to the tubing, and a stabilization device is the best way to prevent that. Intermittent catheterization is a great option if you have the dexterity and mental status to be able to do it. We tend to think of this being used more for our spinal cord injured patients, our younger patients, but my grandmother self-catheterized for the last 30 years of her life up until into her late 90s, and she did great with it. So just because someone's a senior doesn't mean they couldn't learn this technique. And the risk for infection is much, much less than with an indwelling catheter. Here we have closed system intermittent catheters. This is the latest technology, and Shield's going to talk a little bit more about this at the end of our presentation. So you can see the tubing is entirely contained within the bag, so it's staying clean the whole time. Also, some of the newer ones have an introducer tip, an insertion tip or introducer tip, and you can see that on the right side of the screen. That goes into the urinary meatus, and then when you start sliding the tube up in the catheter, you're bypassing all the bacteria. Most of the bacteria that's in our urethra is right there at the opening, that first quarter inch or so. So if we introduce that tip, then our tube is sliding past all that. It's not even touching the sidewalls there, so that reduces our risk of infection by quite a bit. Here's a couple more samples of just pocket-sized ones that you can see how easy it is to carry with you wherever you go. Okay. We want to avoid irritants, scented products, caffeine, alcohol, artificial sweeteners. Spicy food can be a bladder irritant for some people. So notice the patterns. What bothers somebody else may not bother you, and vice versa. So pay attention to what might be triggering bladder irritation or infection for you. Probiotics can help. And these can be in the form of fermented foods or probiotic supplements that you can purchase. And this has to do, we think of probiotics as helping us with intestinal health, but when we get the bacterial balance right in the genital area, this helps protect us from UTIs, because the healthy bacteria that normally grow in that area help keep the populations down of the harmful bacteria. Detection in the elderly. Since elderly folks don't often show the typical signs that younger people do, that burning with urination, sometimes sudden onset incontinence is the only sign. Confusion or disorientation, changes in behavior, delirium, agitation, hallucinations, social withdrawal. These can often be mistaken for dementia, but if they're coming on suddenly, we want to think about, could this be a UTI? My mother-in-law was in the hospital for some other reason, and her mental status was just horrible, and they thought it had to do with the hospital and the environment. And then in the end, her daughter insisted that they test her for a UTI, and it turned out that that was the cause. And the funny thing is, you just would have thought the hospital would have tested that or figured it out, but it was the family that said, you know, when she gets like this, it's usually a UTI. And so the fact they advocated for her, and it did clear up. Loss of appetite can be a sign, inability to do normal tasks, fatigue, weakness, change in gait, having a couple falls, a fall or two. That could be the only sign of a UTI for some people. Fever in the elderly doesn't show up as much as it does in younger people, so it could be very low grade or even absent. Suprapubic pain, so pain right in the lower part of the abdomen, right above the pubic area. Feelings of general discomfort or achiness. Blood in the urine would certainly be a sign of something to look out for. Swelling or tenderness in the testes or prostate. Purulent drainage from around a catheter, or change in the drainage, the character of the urine, so pus in the urine or pus coming out from around the catheter tubing. On the other hand, a positive urine culture alone is not sufficient. We're going to talk about that more here. One of the main problems is that in addition to sometimes having less sensation in this part of the body, elderly folks may not be able to communicate what they're feeling. When you have a catheter in place, there's some different signs we need to look for. Number one is increased leakage. So you actually see urine squirting out around the tube, or you notice the bedclothes are wet. This can be caused by bladder spasm. So as bacteria are settling in the lining of the bladder, it irritates it and causes the bladder to squeeze down abnormally, which is a spasm. Sometimes folks with a catheter will have urgency. So they've been fine with their catheter for a few weeks, and suddenly they're like, I gotta go to the bathroom, I gotta go. And you're saying, you have a tube in, the urine's coming out, you don't need to go. But they're like, yes, I do, I need to go. So that could be, again, that bacteria is irritating them, giving them the sensation of a full bladder. A change in the character of the urine, the color could change, there could be a strong odor, it could be really cloudy and with sediment. And if you're seeing a lot of blood in the urine, it's often a sign of infection, or we'll see that also in bladder cancer patients. Oh, and one symptom relief measure that the Mayo Clinic recommended was just using a warm heating pad if you had that general pelvic ache while you're waiting for the antibiotics to take effect. I just thought that was a nice tip. Treatment. Antibiotics are the main treatment. You want to keep a record of what you've previously taken, because if they worked, it might work again, and if they didn't work, it's good to know that too. You want to complete the full course of treatment prescribed by your doctor. And we used to always recommend getting a culture prior to starting therapy, but that's changed, and we're going to talk about that in a minute. We tend to not use anesthetic agents for the elderly. It doesn't tend to be needed as much. So, antibiotics have their upsides, of course, but they also have their downsides. They can cause GI upset, loss of appetite, and they can put us at risk for other infections like C. difficile or C. diff, which can be a life-threatening infection in the intestinal tract causing severe diarrhea. Antibiotics also put us at risk for fungal infections or yeast infections. I treat a lot of women with yeast infections under their breasts and men and women with yeast infections in the groin skin folds. For my larger patients with a heavy abdomen, I'm doing a lot of yeast treatment in that crease under the belly where the belly hangs over. It's called the pannus. So most of them have had antibiotics that are putting them at risk for these infections. And we can even get a fungal infection in the urinary tract itself. Also, there's a risk of allergic reactions with antibiotics. And when we're over-treating for UTIs, we're contributing to the development of multi-drug resistant organisms. So now a lot of the literature is looking at overuse of antibiotics. And one of the main issues is what we call asymptomatic bacteriuria. This means we have bacteria in the bladder, in the urine, but it's not causing symptoms. And we used to think, okay, urine should be sterile, which is true in most younger people. But what we're finding is that a lot of older folks normally have bacteria in their urine. So if you have a catheter in place, the odds of bacteria just normally living there increase by 3 to 10% per day that you have the catheter. So it reaches 100% within a few weeks. And if we're just giving everybody antibiotics all the time for those bacteria that we're seeing there, we're not benefiting them and we're putting them at risk. We also notice that cloudy urine or pus in the urine is common in elderly folks with and without catheters. So we have to worry about over-treating. And let's see, I just wanted to say, actually back to that previous slide, they're finding in studies in France and the US that we're often not managing appropriately bladder infections. Just even a regular simple bladder infection was only managed correctly 25% of the time. A lot of patients in this sample in Arizona, 39% of them received a prolonged course of antibiotics that wasn't indicated. And they're reminding us that even if we have bacteria in the urine, we don't want to treat unless there's 2 or more of the following: fever, that flank pain, sudden pain with burning, with urination, worsening frequency or urgency, and suprapubic pain. So if we don't have 2 or more of those, we got a question about treating. In recent studies, 1/3 to 2/3 of adult inpatients were treated for bacteria in their urine, but they didn't really have symptoms, and they were being treated against these recommendations. On the other hand, there's a great quote here by a doctor who treats nursing home patients saying, you know, sometimes there's somebody who's having these behavioral changes, they don't have the symptoms, and I go ahead and treat them and they get better. So it's really a tough call, whereas the Emergency Medicine Journal is telling us that a diagnosis of a UTI in a catheterized patient should always be a diagnosis of exclusion, investigating every other possible cause before you treat. So the moral of it is treat the patient, not the urine, and that's Dr. Tricia Elliott's phrase, which I really like. Okay. Some folks end up with so many recurrent infections that they go on continuous antibiotic prophylaxis. And more, Tricia Elliott is really emphasizing the self-start treatment or acute self-treatment. She says the ability to make a diagnosis based on history and symptoms can empower women in self-diagnosis and patient-initiated therapy in partnership with their primary care clinician. With proper education, women were able to correctly self-diagnose acute, uncomplicated urinary tract infection at a rate of 90%. This allowed for rapid, patient-initiated treatment when patients were provided a prescription to keep on hand just in case. And it also made the patients more satisfied. So it's kind of a new way of thinking about it, and even if a patient doesn't have the mental status to manage that, they may have a caregiver who can. And so that can provide overall less use of antibiotics, but more prevention or early treatment for UTIs involving shorter courses. The Mayo Clinic also mentions single-dose antibiotics after intercourse for people who are prone to infections that way. One of the main takeaways here for women is topical estrogen therapy. And I want to differentiate from oral therapy. So taking an estrogen pill doesn't benefit in this way, but estrogen creams or rings can reduce recurrences of UTIs. That's because it's promoting the healthy vaginal bacteria, it's increasing lubrication and blood flow, so less of the harmful bacteria are living down there and we're less likely to get an infection. Also affects the pH. So for women post-menopause who are having recurrent UTIs, topical estrogen therapy would be one of the first things I would consider. This is kind of sad news. I was seeing some articles about a vaccine for UTIs, but unfortunately it didn't get approved by the FDA. I had trouble figuring this out, so I called the FDA a couple days ago, and they're like, no, we didn't approve it. I don't know why, but it had looked really promising, but it's not an option for us now. Alternative therapies like acupuncture, probiotics, herbs, and dietary changes can also help sometimes, especially if it affects bladder pH. I just want to say that not treating is also a choice. Like pneumonia, a UTI could be an old man's friend or an old woman's friend. Unless you have symptoms, you know, like burning with urine, it tends to not be painful in older folks, and if there is, you can always get those anesthetics for the bladder and urinary tract. Hospice patients should be definitely offered a choice of whether to treat or not, but everybody has the right to refuse treatment for any condition. And when we're pressing hospice folks to drink more, we can actually cause increased suffering, fluid overload, water buildup in the lungs. So I just want to remind folks that sometimes not treating a UTI is okay. And also just talking about my grandmother, she did end up with UTIs near the end of her life. She was taking antibiotics. I think she was on prophylactic antibiotics on a daily basis, and she finally decided to stop it because she was 97, she was ready to go, and she was suffering in other ways, so we stopped her antibiotic, and she still lived another year. So here we had thought her life was hinging on this, and it didn't make any difference. Managing incontinence in general will help prevent UTIs. I'm not going to go into that here, but we have references for continence practitioners, because UTIs and incontinence, they can both, one can cause the other. And if you're dealing with incontinence at all, I just want to remind folks of the importance of skin protectants, and Shield can be a great source for that as well. Here's a few internet resources, the National Association for Continence, and a lot of these continence resources are dealing with infection issues as well. So just because it says continence in the title, don't overlook it as a resource for urinary tract infections. And then some just general caregiver resources, because if you're dealing with recurrent UTIs and incontinence, you deserve some support about that. So that's about it for my part of the presentation. I think Amy has a little bit to add here.
Yes, thank you so much, Barbara, for that informative presentation. A lot of great tips there and information. I just want to draw our audience's attention to the jaw all-in-one catheter system, and we have a slide for that, if you could advance that. Thank you. So the jaw is a pre-lubricated catheter that doesn't require any supplies. It's got all of the supplies you need there, including the bag. It's touch-free and helps the bladder empty fully to help prevent UTIs. And then most importantly for a lot of folks, unlike other cath and bag systems, it doesn't require a lot of documentation on UTIs from your doctor in order to be reimbursed by insurance. And it has a much lower patient copay. So it basically allows you to cath anywhere and have that peace of mind to reduce UTIs and lower copays. And then if you want to go to the next slide, this is, that's Aaron Baker right there. He is our spinal cord injury lifestyle specialist. He writes a lot of articles for us. He answers a lot of questions from the spinal cord injury community. You can find him at shieldhealthcare.com/SCI. You can also find his Facebook page at facebook.com/spinal cord injury lifestyle. Aaron suffered a spinal cord injury several years ago, and through a lot of hard work and dedication has been through a lot and has a lot to share, and is definitely a great resource for folks with spinal cord injury. And then our final slide that we would like to point out is our Caregiver Contest, our annual Caregiver Contest. What advice would you give a fellow caregiver? So if you would submit your entry of 150 words or more to shieldhealthcare.com/caring, you could win one of 3 $500 gift cards and probably help a lot of other caregivers out there who need your valuable advice. So that contest ends January 31st of 2018. And now we would like to open it up for questions. See what questions we have here. Looks like we have a question from Yvonne. Barbara, what do you recommend to use for Foley care, hygiene, and what frequency would you recommend?
I mean, I don't think there's any particular products that you need, you know, just plain washcloths, soap and water. For someone who's bedbound, you might be wanting to use no rinse products. You definitely want to avoid any perfumes and, you know, or dyes. We don't want to irritate the area. But once a day is good for most people, but for folks with recurrent UTIs, or, you know, some folks just naturally have more mucus, more secretions in the area. So you may want to increase the care routine if you're having recurrent infections or just noticing more discharge in the area. But we can clean the Foley just like we clean the rest of our body. We don't need special products. You know, sometimes, like I say, we'll use an alcohol wipe just because it's a convenient little right-sized thing and it slides down the tube nicely. But we're not sterilizing the area. We're just keeping it clean and trying to remove crusts, mucus, any kind of residue that's staying there. We want to not leave any places for bacteria to hang out.
And is that something that you would do throughout the day or once a day, or?
Yeah, I mean, if once a day is generally good, but if the catheter, if the area's been contaminated after a bowel movement, then you'd want to do full perineal care again. And also, if the person just feels more comfortable having it done several times a day, it may increase comfort, especially if you're dealing with fungal infections in the area, you're dealing with rashes or broken skin. Keep more emphasis on keeping it clean and dry could help, as well as those skincare products.
Sure, thank you. Another question comes from Krista. Could you touch on what are the pros and cons of suprapubic catheters?
Oh, good question. You know, it seems that a lot of surgeons are reluctant to go to a suprapubic catheter, but I've seen just incredible benefits to quality of life for people with a suprapubic catheter, especially folks who are wheelchair users. And so it's kind of a juggling in terms of the infection risk. When you have a suprapubic catheter, you've got a direct route into the bladder. So we no longer have the urethra. So if that catheter is contaminated, it's right into the bladder. We're already kind of upstream there on the urinary tract. We're one step closer to the kidneys. But on the other hand, the site that the suprapubic catheter comes out of is not in the genital area. It's up on the abdomen, which tends to be a cleaner area with less bacteria. So in certain situations, it seems that the suprapubic catheter is greatly reducing the risk of infection, whereas in other situations it might increase it. So obviously it's really got to be a case-to-case basis, but I've seen, you know, some wheelchair users be much better able to manage because they can access the catheter right there in their lower abdomen in a way that they can't in their genital area because it's much harder to reach. So I've seen a suprapubic catheter be a great quality of life benefit, and I've seen it reduce infection rates as well. But it's definitely not an across the board. You don't want to do unnecessary surgery on somebody if you don't have to, but it's a really good option to consider when things just are not working out with your current system.
Okay, great, thank you. Another question. My mom's urine has a strong odor, but the doctor says there's no infection. What could this mean? So
again, that could be one of those cases of what we call the asymptomatic bacteriuria. What you want to consider first is she dehydrated? Can we push fluids? Is she someone who's willing to drink more fluids? Is it going to ruin her day if we're trying to force feed her fluids all day? Or can we work with her to increase her fluids? That could clear up the odor right there, because dehydration is the most common reason to have increased urinary odor. But it could be that she is just colonized. Maybe she's someone who has a catheter long term, or she's, you know, up over 85, where there's, you know, I think it's like a 30% chance of just having bacteria living in the urinary tract because we don't have the lining, the active lining that younger folks do. So she just may be someone who's living with bacteria in the bladder and the urethra, and but it's not causing her problems in terms of fever, urinary pain, increased frequency or urgency, and it's not contributing to her incontinence. So in that case, your doctor is following these newer guidelines of not treating asymptomatic bacteriuria. So socially, it may be awkward to have that odor, and that was an issue for my grandmother as she near the end of her life. I think she also had a low-grade bladder cancer, so her urine was just really foul-smelling, but she didn't want any treatment. You know, she was fine with just letting it go, but sometimes the odor was an issue. Just if she was incontinent, it would fill the room. So odor management became a quality of life issue, but the bacteria that was causing the odor wasn't a problem. So again, it can be socially awkward, but there are ways to manage that, and it sounds like your doctor is really making some good choices and following these current guidelines.
Are there products out there, Barbara, to help with urinary odor?
I'm trying to think.
Certain deodorizers?
Fine. I'm thinking if there's a product we can take for stool odor. I don't know of anything that particularly helps with urinary odor other than just increased fluids. But the incontinence products, certainly a lot of the incontinence products have odor combating agents in there. So different incontinence products can really vary. And in fact, I found a study, I think it was in my wound ostomy continence nurse journal, and it was comparing odor profiles with different incontinence products, and they were using wine tasting technology for people to sniff the odors of these various incontinence products that were saturated with urine. And so it was pretty interesting, but it makes sense that it's a real issue, and so I'm glad that they're working on it. The manufacturers are working on trying to develop products that will combat the odor the best.
Okay, great. So you talk a lot about treating the person and not the urine. Are you seeing a trend at all in a reduction in overtreatment or more antibiotic stewardship in the medical community?
Yeah, I do see that where I work more, and especially when I get to work with the infectious disease doctors, they're very mindful of that. And you know, thank goodness most folks with UTIs aren't needing to see an infectious disease doctor, but when I interface with them in the hospital, which I do for a lot of my complicated wound patients, they are very mindful with the antibiotic stewardship, and so hopefully that'll eventually trickle down to our primary care doctors. But you can see the pressure the primary care doctors are under, like with, you know, the woman who says my mother's urine has this strong odor. They want to try to help, and in those cases where we're dealing with delirium, you know, is it delirium, is it dementia? We've got behavioral changes that seem like sudden onset. You can't always blame those primary care doctors for giving it a try to see if it would work. So it's a really tough call, and thank goodness we do have the infectious disease specialists kind of helping give us oversight over that whole situation.
Okay, great, thank you. Well, I think that concludes our webinar for today. I want to thank you, Barbara, for your knowledge and expertise and your presentation style on this topic. And I want to thank everyone for attending, and as a reminder, you can go to shieldhealthcare.com/webinars for a recording of the webinar as well as for a copy of the slides. Did you have anything that you wanted to add, Barbara?
I don't think so. Thanks for having me today, and I thank everybody for joining us.
Okay, excellent. Thank you so much, everyone. Have a great day.